Hello, you are listening to 1 in 2, a Manchester Cancer Research podcast, brought to you by the University of Manchester and the Manchester Cancer Research Centre. With 1 in 2 of us receiving a cancer diagnosis at some point in our lifetime, it has never been more important for our research to improve the outcomes for people affected by cancer. I am your host, Sally Best, and throughout this series, I will be speaking with Manchester cancer researchers about their innovations, discoveries, and projects that are changing the landscape of early detection. In this episode, we speak to Dr Jen Davies-Oliveira, a researcher and PhD student at the University of Manchester, and Stewart O'Callaghan, the founder and chief executive of Live Through This, the UK's only LGBTQIA+ cancer charity. We discuss challenges that LGBTQIA+ people face when accessing cancer care in the UK, Jen's research project in alternative cervical screening, which aims to tackle some of these inequalities, and Stewart's experiences as a person living with cancer, how they came to set up their charity, and how it is aligned with research. Hello and welcome to our special episode. We've got Stewart and Jen. Say hello, guys.
Hello.
On demand, love it. How are you feeling?
Yeah, good.
Fantastic.
It's Friday.
It is Friday. How are you doing, Stewart?
Yeah, good. Long journey up. Train got stuck halfway. We almost had to reverse back down the tracks to get back up again, but made it.
Nightmare.
So glad to be back in Manchester.
Let's get on to introductions. So I'll start over here with Stewart. Please, could you introduce yourself? Who you are, what you do, your pronouns, just in a little synopsis.
Yeah, so my name's Stewart O'Callaghan. I use they, them as pronouns, and I'm the founder and chief exec of Live Through This, which is the UK's only LGBTQIA+ cancer charity. I set it up because I have chronic myeloid leukemia and felt the difference that our community has firsthand. And now we support patients, educate professionals, and make new resources.
Fab. Jen.
So I'm Jen Davies-Oliveira. My pronouns are she, her. And I am a researcher at the University of Manchester, but also a gynecologist. And I work, so my PhD focuses on alternative cervical screening methods, including urine self-sampling. And I think that's pretty much it. I guess we'll find out a bit more as we go along.
We will. There's lots of things that you forget. You always look scared as well when you're doing your job description, like you're going to miss something out.
It's really interesting, actually, because it was really easy when I was just a doctor. I'm a gynecologist. This is how many years of training I've done. This is how big the bags under my eyes are. And now just too many hats. So I get confused.
You do. Well, I'm Sally Best, she, her, and I am your podcast host. I am not a gynecologist and I'm not a CEO, but I love speaking to them. So it's great. Stewart, I'm going to put you on the hot seat again. So you've said that you've got chronic myeloid leukemia.
Yeah.
What does that entail?
So it's a really rare blood cancer, super rare. And I got it when I was 29, which makes it even rarer. And for me, it's a disease that isn't curable. So it's managed and I take medication pretty regularly. It's just a oral pill and I'm treated as an outpatient. But even with that, I've had that experience of people not really being able to offer me the support I was looking for, people not really understanding where my identity is sort of crossed over with the cancer experience, and also just asking questions as well of my nurses and clinical team about my health and where things were going, and just getting no real answers, which is what really drove me to go into this work. So previous to this, I was a tattooer for 10 years, so it definitely was a bit of a shift. Mm-hmm. But it's a good area, and I think it's nice to be in an area like cancer care and thinking about inequalities and progress, and that's why it's really nice to meet Jen and the work Jen's doing.
Yep, fab. And you're both a member of the, LGBTQIA+ community.
Yeah.
Correct.
Which one of you wants the lovely job of telling us each one of those letters?
So I can start.
Are you going to split it into
the easiest bit? So lesbian, gay, bisexual, transgender,
intersex,
queer or questioning, intersex, asexual, asexuality, and plus, because of course people also identify as different, as other identities. So one would be pansexual, for example.
So Stewart, you identify as queer. Mm-hmm. Okay, so I'm just wondering if you could kind of explain your journey as a service user, because you've got cancer.
Yep.
So, I mean, what's your treatment experience been and your journey from diagnosis to treatment as a queer person with cancer? What's that journey been like? And what was your stage of diagnosis to where you are now?
Yeah, so blood cancers are usually diagnosed in a bit of a rare way because of their symptoms and the way they show up. So I weirdly had food poisoning, which didn't really resolve itself. So I had to go via A&E, and that's when the blood work was off. But I was living in Germany at the time, and it was an odd thing to sort of be diagnosed in a country where it's not your sort of natural language and you're trying to understand how this stuff works. So I made the decision that actually I should probably head back to England so I could have treatment in language I understood and find support I needed. But what that meant as well was actually stepping away from the support network I had, because I'd built a life out there for my work. So I sort of came back almost needing more support than ever. I went to Brighton in first case. And at that time I was really struggling with the side effects, and treatment doesn't really agree with me, unfortunately. So I was, having mobility issues and lots of other things. And when I went looking for support, I specifically said I need something LGBT. And, I came out when I was 13. I've kind of grown up queer, as it were. It's my whole life. It's my community. It's what I know. And there was just nothing available, even in Brighton, which was shocking, And the things that they offered me was go play sport with the boys. And it's like, well, not only can I not really walk, it's also not really going to work for me for other reasons. So it really did kind of leave me without support for quite a while. And then that was whilst I was failing different treatments, going on new ones, being put in for trials. There was quite a lot to handle. And the whole time I never really felt like I had an opportunity to speak to someone else from my community who's maybe understood where I was coming from, whether it be a different cancer or not. And it was actually taking part in someone else's research that gave me the first opportunity to talk about my identity and my disease at the same time. And from even just being in that research interview, it really made me understand the importance of being able to have both those concepts in one conversation. And that's what led me to think, if I've gained so much from just this piece of research, maybe there's other people out there who feel as lonely as I do and will want to connect on the same thing. And now we've managed to make peer support and do that. And I've almost made my own trap, because now I'm the CEO of the charity, so I can't be too friendly with them. There's kind of this awkward step of professionalism, but it's really nice to be able to provide that service for other people so they don't feel so isolated.
And we'll come on to that, but I'm just interested, what was that research that you participated in?
Oh, so this was a piece of research that was all about LGBT people with chronic health conditions, and it's done by the Access Care team in King's College, and they have many different arms. I think this was Access Care C, if I'm remembering rightly. And then now they've made a document for clinicians which actually guides people through the right way to speak to patients and the way to support them. I think it's called the ABC of Care.
Okay. So you're diagnosed in 2016 and charity was set up in 2019. What was that journey, and what was the inception of it, and what inspired you and drove you to set up this charity? Because, I mean, it's the only LGBTQIA plus supporting and advocating charity for cancer in the UK, which is just bizarre.
Yeah, I definitely feel like that. And I think that's what drove me to do it, was the lack of one being there. And it's the fact that as a patient, sort of going out and asking these questions, not every patient will have the confidence to come out to their care team to get that support. They maybe want to go away and look it up independently, that kind of thing. And whenever I was doing that, I didn't really find anything. Or if I found something, it was one small project that got defunded within 12 months because it was on a limited thing. So I wanted to provide something that had a little bit more stability and reliability, because I knew that's what I would be looking for. So I actually went to my Macmillan Centre inside my treatment hospital. I had a really fantastic person there who's now become a colleague, Lindsay Farthing. And I went in and kind of asked them a question I knew they couldn't answer. And I was like, do you have an LGBT service? And they didn't, and they knew that. So I just propositioned them and said, do you want to help me make one? And I was always grateful for the fact Lindsay just said, let's do this, and gave me all the resource and support. And I think that's what's really helped it going. And then as for turning it into a full charity, that wasn't the original intention, but somebody just on an offhand in that same Macmillan Centre said, have you thought about turning it into a charity? And I hadn't really thought, I've never been in the charity world. I didn't understand how it worked, but I thought about it a bit longer, did my reading, understood what it meant, and realised actually, yeah, it would take a big commitment of myself to do this, but also I'm incurable. So there's no way I'm going to get away from my cancer. So why not do a lemons to lemonade situation and see if I can build something out of it?
Yeah.
So
it's a great story, and I think it's sometimes the projects that see the greatest fruition are those that are really personal to you, and it is personal to you, and we'll kind of go on to barriers that are faced by people in this community, but first-hand experiencing them is a lot different to knowing that they exist.
Yeah, and it's something that people, especially in the clinical space, really welcome at this point. I think they've really embraced the idea of that expert by experience thing. But at the same time, although we do see that, we also see there is still a bit of a difference between the voices that get listened to in that expert by experience room. And typically, they are people who have the resource to take time off in the middle of the day and sit in these rooms, or, so you start seeing the same demographics every single time. So I think there's also an acknowledgement we have to take that, I sit as a bit of an exception in that. And I think people who maybe listening or thinking from a clinical point of view of like, oh, that's great, I wonder what I could encourage in my local area, make sure that you hear from voices that you maybe typically haven't heard from before when thinking about these things.
Yeah. And I mean, it's really shocking that you are the only charity of this nature that exists. Do you think that is just because of kind of previous exclusion?
I think inequalities in cancer is kind of a new thing still. It's a bit behind compared to other things. I was speaking to someone from the care environment recently who came into the cancer space, and they were shocked by how sort of behind cancer was, which was something quite interesting. And when I first started doing this work, I was told multiple times by people that there's no need for it. They've done it in the past. It didn't take off. Macmillan did one event, no one cared, and then that was it. So I think people had tried before and there'd been more small projects. But I think, especially what I found, the commitment it takes to build something is extensive. It's exhausting. And in the same way that these things can be passion projects, they can absolutely be open to burnout. So I think that's why when we see people doing good pieces of work, it helps to resource them, open doors, give them support, that kind of stuff. And I've been lucky to have that from certain people in the cancer space.
Yeah.
But there definitely, I think, in the beginning was a lot of disbelief as to this doesn't need to exist, or, this big charity's done this one LGBT project 5 years ago, you don't need to be here. But I think there's extra power in having a charity that's patient-led, and it can have that view. And also, I'm not making the recommendations we do from the charity just off my personal experience. We're engaged in research, we're plugged into the clinical sector, we're doing peer support, we're hearing directly from people. So we're always making sure that the direction we travel is what our beneficiaries want.
Yeah. And I think that's really key, isn't it? Research that benefits the community, not just personal interests.
Absolutely.
And yeah, I mean, I think I'd like to go on to that, the way that people kind of view these minority groups as optional.
It's that. And I think something I've come to terms with recently is it's the pain of retrofit. So the way that health system's been built, it hasn't been built for minority communities at all. So that's why it feels painful to retrofit them. And it takes more money and it takes more time and it feels uncomfortable. Whereas when we have the opportunity to be inclusive in our innovation, then we can future-proof things. So this is why research like Jen's is so important, because it's making sure that it's inclusive at the nascent stage of us bringing in new potential techniques for screening and things like that. And I think that's what needs to happen more, making sure that we're inclusive from the start, so we're not having to do this costly, painful retrofitting of services 5-10 years down the line when we realise it isn't serving people. An example of that is the U-Screen pilot in North East London with the self-sample for HPV with the swab, and they based it on the call and recall register. So by definition, it was excluding trans male patients because they were going off a system that already excludes them. But that was a blind spot they had. So they didn't do it maliciously, but it just shows, again, how if we don't really think about inclusion from the real beginning, then we might potentially be missing really useful data to understand people who might benefit from these changes most.
And could you explain a bit more about that U-Screen program and what you mean by the call and recall?
Oh, yeah, sorry. So
no, don't worry. You're just very erudite, and I'm like, take it back a step.
So the call and recall system is the system by which we call people up for cervical screening. It runs sort of in the background, and it's how you get your invitations via letter, and you'll be sort of held on this list of you're ready to be called because of certain age or gender markers, things like that. And people can be opted to take off that list, that prior notifications list. If, for example, they have hysterectomy, they no longer have a cervix, it's no longer relevant. There's aspects like that. But actually getting yourself on the list isn't really possible at the moment. There's an update that's working towards that. But so for people who are trans male and we've re-registered their gender with the GP as male, that pulls them off the call and recall register because they have an entirely new NHS record. So they have to go in and speak to their GP and ask for that test, which is a multi-stage barrier because then they have to disclose that they're trans. They have to then go in. There's also the barriers of if the lab accidentally refuses the sample because it's not registered as a female sample. There's all these steps. And unfortunately, the majority of these steps remain a burden on the patient. The patient has to drive all this stuff. And that's where it becomes inequitable when you consider it to the cisgender female peers who get the automatic reminder. They don't have to put it in their calendars. It comes into them. And that's not to say, the process is pleasant for anybody.
Yeah.
But when we think about the access to the service, that's the bit that sometimes needs the revision, which is what NHS are trying to do in the background.
Yeah. And I guess not only is that process very arduous, but it's also it might risk late diagnosis, which is
absolutely
an even further kind of issue with that. And I mean, just touching on this, so is it the same for trans men that would have had breasts or maybe still have breasts and haven't had their reconfiguration surgery? Would they be removed from the breast cancer screening?
Yeah, so how it works basically is if you re-register your gender with your GP, you get an entirely new NHS record.
Okay.
So what that means is now your, let's say, male record exists as any other standard male record in the medical system. So therefore, if there is a screening process that's based on a gender marker, you'll be excluded from it. So if we think about breast and cervical. So you are right. There are people at the moment who will be registered as male, but still have adequate breast tissue for screening. And at the moment, again, they have to self-advocate. And I'm pretty sure they go through a symptomatic pathway at the moment, but breast screening program is looking if they can make this system better, but it would still be a case of self-advocacy, I think. But it is this aspect where the systems, as we said, are sort of built in this way where they go off that sex marker. And when you get that new NHS record, there is that issue because we don't have a sex and gender markers on the record. It's just all consolidated into one. So that's why it can be pretty tricky about calling people up for the right tests. And it's also why patients need to understand when they do re-register their gender that this might happen. Yeah. So that if that burden is now on them, that they can make those points. But it's also part shared by their GP or by the breast clinics who, for example, if you think about cervical screening again, there are systems by which you can generate your own lists on EMIS or System 1, whichever system you're using, so that it actually does flag and give you reminders of when to invite these patients in. So you can take that extra process on. But it's just not all GP patient practices are doing it.
Okay, but that would be something that you'd advocate for.
Yeah, and Owen Carter from RM Partners created a step-by-step process for EMIS, which you can access on the RM Partners website. So that's the Cancer Alliance in West London. And I recently spoke to a practice in Hebden Bridge who have done it for System 1, and I'll be getting access to that too. So if anybody is on those systems and they want to know how to create those lists, the information's out there and just get in touch.
Okay. And did you work on a non-gendered breast screening assessment, self-breast assessment?
Yeah. So because the breast screening program starts at 50 up, there's obviously a large proportion of people there who will want to be understanding what's normal for them. And when we think about people who access transition, that normal can change. Obviously, you might grow breasts, you might have them removed via top surgery. So it was really a campaign by which we could work with trans people to find out, how do you want the information? What's going to work for you? And I naively went in and thought, let's do a trans male poster and a trans women's poster. And then when we did the focus group, they were like, why? Why? What? You're just falling into the same trap. And instead, they just said to us, tell me the symptoms. Find me a way to see the symptoms without having to show me pictures of bodies and all these things. Because they also pointed out that if the body doesn't look like them, it's harder for them to know how they relate to the information, if it is for them. So that's why we created the Chest Check 101 with Copperfield, and it's on fruit. And it's also really useful because if we think about, for example, these trans men who have top surgery, so they have that bilateral mastectomy with a masculine chest reconstruction, there's still some tissue that needs to be monitored for breast cancer, but they can't go into the standard screening because there isn't enough tissue for the mammography. Okay. So they need to be thinking about if they do notice a change, like a lump around the nipple or up into the armpit, things like that. So it was a project that was done with Copperfield, but also with the community. And we had focus groups and multiple stages of development. And I think that's why it's been so well received. Yeah. Because people told us exactly what they wanted to see and we just delivered it to them.
Yeah. That's the thing to remember. There's a patient at the end of everything, isn't there?
Absolutely. And I think there's some hubris in the fact if you think you're going to go in and pick the amazing solution without actually speaking to the person who's going to use your solution, you're setting yourself up for a fail. Yeah. You're much better thinking about co-production right from the beginning. And this is in research too, all the way from the co-planning stage, rather than this is a product I've made. Do you like it? Yeah. That's not really co-production.
No. And just kind of an aside from that, but say if there was a trans female that was taking hormones and she was transitioning, would that put her at greater risk of developing certain cancers?
Yes. So a greater amount of estrogen circulating in the body obviously has some changes, like growing breasts, things like that. And that obviously can increase your risk. If we think about a trans woman's risk of breast cancer compared to a cisgender man's, it's about 46 times greater. So that sounds like quite a lot, obviously.
Yeah, it does.
But it's actually a little bit lower than cisgender women. So, and when breast cancer is identified, it seems to have quite a female pattern. So this is why they say that trans women can access breast screening as standard. And obviously those who've re-registered their gender as female on the record will be automatically called as standard. So actually the process works pretty well. Okay. But when it does work and someone gets called automatically and they go and they have a good experience, it can be incredibly affirming. So in our campaign, Best for My Chest, we have Sophie in the campaign, and she talks very openly about before transition, she didn't really feel connected to her body, didn't want to look after it. And actually transitioning made her really understand the love she had for her personhood, the way she wanted to look after her body, and attending screening and being treated properly was really affirming for her. Yeah. And it made her have a really fantastic experience, which is going to then tell her to tell her friends and encourage people to go, which is a much better outcome than if, for example, someone had been, maybe not so accepting of Sophie, and then she would never go again when it's the screening that she absolutely should be accessing. Yeah,
100%. And it's now part of her anatomy, which is really important. Kind of taking a bit of a backtrack, I'd like to just ask both of you about some of the barriers in cervical screening that LGBTQIA plus people might experience.
Well, I mean, there's universal barriers. So the three main ones are access. So for everybody, that is. So actually going to your GP, finding time to do that, going in and having it done when you're not on your period, etc. So there's a lot of access barriers there. But of course, so people feel embarrassed about having an intimate examination, and then they also feel discomfort or pain. And obviously that ranges. So some people don't feel any discomfort or pain at all, and some people it's really severe. So there's a big spectrum there. So those would be the main general barriers for absolutely everyone who is having this test. But specifically for our community, the LGBTQIA plus community, I would say that so it's really interesting, the research that we've done asking people about barriers. So we had 503 completed responses, just under half identified as transgender and half as cisgender. So if we sort of separate those two groups out, obviously the embarrassment, the access and the pain were there amongst the top barriers. But what was really interesting is in the transgender population, it was a lot about the provider. So in terms of being misgendered, so they'll go up to the person at the front desk in the GP and they'll go, I'm here for my cervical screen or to be with a nurse, and they'll go, I think you're in the wrong appointment. So just throw away comments like that. So that's being misgendered, being in a waiting area that's full of pink, which is a color that's very much associated obviously with the female gender. So that really puts people off. Not having LGBTQIA plus sort of, if you have a flag on the wall or some material that shows that you're a friendly practice. So all of these things are big barriers, but specifically for the transgender population. And then more within the cisgender population, it's more about those common barriers, but also not being able to share, what their identity is as well, or feeling that like they can't be open about that.
Okay. And so I know you've spoken on this podcast before, but some people might not have listened to the episode, but they definitely should. But I mean, could you just give us a bit more of an overview about what it's your PhD project, isn't it?
Yes.
Is that it's kind of looking at in terms of addressing these barriers?
Yeah, so my PhD as a whole is looking actually at urine testing instead of this test that we do now, which is a speculum examination. So it's a plastic instrument that we pop inside the vagina, and then we look at the cervix and take a sample from the cervix. And that's how cervical screening currently works. And, you know, I'm sure I speak for everyone. Even though I'm a gynecologist, I still find it a strange examination to have done personally. And I think it is a difficult one because you feel very vulnerable, and obviously all the other things that we've just spoken about. So that's how it's currently done. And unfortunately, we've just dipped under 70% of the population actually going for a screen. And we know that cervical screening, this process, has reduced the number of deaths in the UK since the 1980s from cervical cancer by up to 70%. And it could be higher if we had a higher screening coverage. So we know it works, but it's just a case of how do we get people screened? So I'm looking at a urine test because now we test for the virus known as human papillomavirus, but high risk strains of the virus, which you have to have cervical cancer. However, 80% of the population will have human papillomavirus at some point, but the majority will clear it. But there are a few where that virus will interact with their cervical cells and cause a cancer. And it does take a long time. So it takes 15 to 20 years for that cancer to develop. So we've got time. So that's why screening works really well. And the interval's 3 years in England, 5 years in Wales, because we know we can actually make it a bit longer. I feel like I've gone off tangent.
Don't you worry. We're all about tangents.
So essentially, so my research is looking at a urine test, testing for that virus, because that's what the cervical sample does. So we're just trying to compare the two. So I've done a big study looking at comparing and looking at test accuracy, and it's looking promising. So it looks like urine could detect the virus just as well as a cervical sample. And of course, that gets rid of that first initial barrier for the majority of people, which is the examination.
Yeah.
And also on top of that, we can also send it to people's houses and they can just do it at home. So second barrier gone, which is the access barrier. So that's the sort of bulk of my research. But essentially, a few people from the Christie came to me and said, this research sounds interesting. We would like to be more inclusive. Why don't we do some research within the LGBTQIA plus community? So it actually came from a few other people. And of course, the research I was doing. And I said, well, you know, the literature there's not much out there. We don't know much about cervical screening within the LGBTQIA plus community. We know a bit. There was a bit of research in 2013, actually in Manchester, with 500 lesbian and bisexual women. And we know that they were less likely to go for screening, but it's not a huge population. And of course, within the transgender community, most of the research comes from the USA. And that's, of course, very different because they have to pay for these things and there's insurance involved, etc. So, but we do know that we're pretty certain that they're less likely to go for screening, the whole community as a whole. And of course, lesbians and bisexuals, partly because, well, lesbians mainly, they were misinformed. I mean, when would that have been, Stewart? I'm not sure. Maybe sort of...
I still hear about it now.
Yeah,
I asked you this question the other day.
And did I not have the answer?
You
did
have the answer, but you're going to go on to explain this.
I mean, but there's a lot of misinformation saying that because you're not having... because you're a lesbian and therefore, the assumption is you're not having sex with a man, then you would not be at risk of cervical cancer, which is, of course, completely incorrect. Anybody who's sexually active really is at risk. Pretty much everyone. I mean, I would say absolutely everyone is at risk. It's really important that everyone goes for screening. So this misinformation meant that less people who identified as lesbian went for screening. And so therefore, that these people have been failed really with misinformation from the healthcare system over the past 10, 20 years. So, so it came from a few of us coming together and me saying, well, this test is looking good and this could really address barriers for this community. Let's explore them. And so, yes, we went about looking at how acceptable would a urine screening test be to this community, who we know are less likely to go for screening. So if we can increase the number of people being screened, that would be fantastic.
Yeah.
So that's how we went about it. And we really wanted to collect data on kind of knowledge around HPV, because we know there's a lot of misinformation about the virus and whether it causes cervical cancer, and also barriers, specific barriers, and also general barriers, things that could help people go for screening, and also specifically looking at self-sampling methods. And obviously we've spoken, so there's two different ones. You can do vaginal sampling, and where you take, I think I've described it quite a few times now as like a COVID swab for the vagina. And you can also do that at home. And that's something that will probably become a reality for us in the next few years and an option. And Stewart just talked about the Uscreen study. So they are looking at vaginal self-sampling and urine sampling. So that's the research that we are doing.
So on the Uscreen, that was done in, was it East and West London?
Northeast, I think.
Northeast, okay. And that was looking at the acceptability of vaginal swabs.
Mm-hmm. So it's looking as well at the feasibility.
Okay.
So essentially, if we're going to roll out vaginal self-sampling as part of cervical screening, then we need to know that it works on a big scale.
Yeah.
So that's what Uscreen are doing. And actually, we have the same thing in Manchester being done, so-called HP Validate. So these two studies are going to inform the cervical screening program here in England and in the whole of the UK as to whether we can introduce vaginal self-sampling as part of the national screening program.
Okay. And with that, so there's 9 other countries worldwide that use this. Why the heck isn't it here?
I know. I mean, I think we're behind. I think I was on a meeting. So we're part of so we know that the World Health Organization launched in 2019 a campaign to eliminate HPV, eliminate cervical cancer, because we know it's caused by a virus. We can vaccinate against it, and we can screen against it and treat people with precancerous disease, and therefore, eliminate the disease. So there's a coalition that has started in the UK called the HPV Coalition, and with fantastic people in that, amazing people that are doing amazing work across the whole spectrum of HPV work. So not just cervical cancer, because we know that HPV also causes other types of cancer. So I can go through that.
Go on.
We've got vaginal and vulval. They're less common. So all the rest of these cancers are less common than cervical. So that's why we know about cervical. We've got anal, we've got penile, and also oropharyngeal, which is the mouth and the throat. Any I've missed, Stewart?
No, that's it.
Good. So this coalition has been started, and within that coalition are stakeholders such as the Eve Appeal, who are a charity that deal with gynecological cancers, and Joe's Cervical Cancer Trust as well. And they were just saying, why haven't we got self-sampling? All these people keep contacting them going, can I do a self-sample? So so Professor Crosby as well, who's leading on this research, keeps getting emails and messages going, I can't have a cervical screen in the way that it's been done currently. Can I give a urine sample? So there's a real drive for it. It's just that we need to get it done. But the problem is you have to sometimes jump through all these hoops to make that happen. But these two studies, they are being done. They're almost, I think that they'll be reported soon. And I think the middle of next year, I think is when they'll be looking at the evidence and deciding whether we can move forward with self-sampling. And urine will be part of that discussion, but we're a little way behind vaginal sampling.
So that's a kind of answer to those people that are saying, Jen, when's it going to be available? Yeah. And when I say people, I mean me.
Yeah, hopefully in 2 years. But yes.
When you called out to this community, you used the term people with a cervix.
Correct.
Please, could you explain to me why?
The LGBTQIA plus community is really heterogeneous, right? There's a really, it's such a diverse group in itself, and you could argue being all lumped together. But there's a reason for that. It's a community that is minoritized, has been discriminated against. And, I think we feel solidarity with each other. But I decided that I think it's really important a lot of the barriers that we face are all are similar. They're the same. There are a few different ones. So decided to keep it broad. And we had, we did do co-production from the beginning, Stewart was talking about. And I think, I'm so glad that we did that, because it just meant that from the very beginning, I didn't really have an idea of how it was going to go. I mean, obviously you read the literature, but I wanted to hear from the community. And it was a mix of people all across, and they were very happy for this to be a community project. So we kept it like that. But of course, within that survey, almost half of respondents identified as transgender. And of course, we know that percentage-wise of the population, you've got 10% who identify as LGB. Mainly, and then from a transgender perspective, it's about 1% to 2%. So it's a much smaller percentage, and yet we were finding that half of respondents were actually identifying as transgender, which just shows how important it is to that specific subset of individuals. And of course, most people who are transgender will not identify obviously as being a woman, and so therefore we felt it was really important to use inclusive language, which obviously we discussed from the beginning by co-producing it with our group, that it was important to be really inclusive in the language. And so we then used, I guess, more of a clinical term in many ways, but people or person with a cervix. Which is clinically correct, but also very inclusive of people who do not identify as a woman. And of course, we were specifically targeting transgender individuals within this piece of research.
And so is that where exclusive language, additive language, and then inclusive language? Is that how it goes?
Yeah, that's how I tend to talk about it. So you kind of have your standard language, which is what you typically see. So, say, for example, we talk about breast screening, it's kind of the same as cervical. So whichever example you take, really. But if you would just say women of this age should go for screening. And that's fine. It's what we see all the time. But as we've touched on, it actually misses out potentially trans people and other gender diverse people who may need to access that service, may not identify in the same way. And also, it doesn't really give a lot of clinical accuracy if someone's potentially had that piece of anatomy surgically removed. Yeah. So someone's had a hysterectomy, if they've had a mastectomy, because if that's the case, you won't need to go for those screenings. So again, it's all about eligibility, and especially when we're talking about access to these services and also research, you have to be very, very clear about these things because they are your inclusion and exclusion criteria. So then you have the additive language point, which is women and trans people or women and non-binary people. And some people use that. And especially you see this more commonly in charities that have a history with women's health as a topic. They all sort of go for this part. And that's fine. Some people use it. For me, my preference is kind of the more new NHS way, because the women and still has this othering. It kind of has this idea of like, this is, our main focus, but potentially there's with these other people. Yeah. So I really like the NHS's new approach, which you can see on their web pages. CR UK also does this, and Macmillan's moving towards it. So it's obviously like the way people are moving, and it just speaks directly to the person. Yeah. If you have breasts and if you are between these ages, you should get screened. Yeah. If you have a cervix and you're between these ages, you should get screened. Yeah. If you have breasts and you're between these parameters set by this study, come and have a chat with us. Yeah. And then that leaves it to the person. You're not telling them how to identify. You're not telling them this. And if you want to, so there are no words being forgotten, you can add a supplementary statement. This might include women, trans men, non-binary people. So there's no one being left behind. But then it saves you making an assumption on who that person is and the eligibility to what you're doing. And you get to be quite specific about, actually, this is where we're going with this is what it's about, and this is who it pertains to.
Yeah. And I think, again, to echo, there is nothing more dangerous than excluding people from screening.
Absolutely. This is life-saving stuff, So, and also, work like Jen's provides a new direction. Yeah. We touched a little bit on inclusive innovation, but also there is ample existing messaging that's in the standard format that we've just touched on. So Jen adding something new doesn't remove any of the pre-existing standard language. So you still have legacy campaigns from Joe's Trust, from Eva Peel, and so on. And even these large charities have very inclusive language. Eva Peel did the fantastic HPV Has No Gender document. So it's this understanding that, again, screenings for everybody, provided you have the anatomy and the eligibility to attend. And if you do, you shouldn't be excluded by its messaging and be left wondering if it's for you. And the same goes the other way. So, if you say, women of this age need to go for screening, and let's say it's cervical, a trans woman wouldn't don't need to go for cervical screening. She doesn't have a cervix. But if she gets that letter from the automatic invitation, she might be confused. So again, it's that ability to be very specific, or at the very least have the clinicians who are running these things understand the ins and outs of their eligibility, so we're not accidentally including people in our appointments or research that shouldn't be.
I think that's one thing that I want to pick up on a bit is that healthcare practitioner education, because I mean,
or lack thereof. And I think generally there's the other issue when we do see LGBT stories in health education, it's usually HIV. Or it's sexual health based. It doesn't really go beyond that, which is why even as us as a charity, we meet people all the time and we have to tell them why we exist, because they've never thought about pairing these two things together. Whereas, as Jen's pointed out, if you read the research, it's obvious that we don't attend screening at the same rates. We're less likely to go to the GP if we have a symptom. You know, we have barriers of access, especially for trans people who re-register their gender. There's myriad reasons why someone might not be getting screened in the same way.
And I'd like to come on to that in a bit, but we have the two of you and we've not quite tied the knot as to why we've got both of you in the room. So how are you involved in Jen's research?
So the way Jen and I met was like an interesting one. So basically, Jen got in touch because Jen was doing an event to launch her research in Manchester, or some studies about it, on results with the community.
It was an Answer Cancer event about cervical screening in the transgender community.
And
online.
And then, but I'm thinking about the one in the home in Manchester.
I went to that one.
So and
fabulous.
so we've sort of been aware of each other and shared a couple of emails and bits and bobs, and then Jen got in touch and said, I'm doing this thing and we're looking for people on the panel. Who do you want to be on it? I was like, well, me, obviously. so
of course I lucked out.
So
they're standing right here.
Actually, that's not true. You actually suggested someone else initially.
True.
Because you're very humble.
Very modest.
Yes.
But in actual fact, you were like, me?
Obviously. So I travelled up and I was so impressed, not only by the work and the quality of the work and the findings and the number of participants, which I think can't be understated. It's quite hard to get a large number of our populations take part in research. So that's fantastic. But the research was cool. I'm really interested in urine HPV because I really like this idea of inclusion and innovation. So it was like ticking all these boxes. But the other thing that I thought was so fantastic was that it felt like a community event. And I'm, a patient as well as a professional, and I sit on both sides, and I also do obviously community work on the LGBT sort of side. And it's so rare to see those worlds come together. And the way that Jen's event worked in that way was just, it's left a massive impact on me. It's changed the way that I work moving forward. It really makes me see the benefit of bringing people in and launching stuff in a community space, in a nice feeling. It even had performances from people who were on the panel. It just felt like a really good way that also not only updated people about research, but also then made them feel that the research felt accessible, safe, they had a stake in its direction, and they'd be probably more likely to engage with self-screening when it comes to market. So for all those reasons, that's kind of what got me, I think, more invested in Jen. It's just really interesting how things happen. And sometimes when things happen, you don't realize what impact that's going to have. And so, for example, the survey itself, I mean, it was an incredible response. I'm not quite sure how we managed it, but I genuinely think that it just shows how important this research is to our community. It's just so important, which I didn't think that the impact would be that big. So that was the first thing. And then the second thing is that one of the people who is part of our study team, Emma Thorpe, it was actually through a family contact who worked for Manchester Pride that we were able to then access the amazing resource and events company that is Manchester Pride. I mean, just incredible. And they were also really enthusiastic about the project and were happy to work on it and have a team on it. And we could never have dreamed about having, it was just such a beautifully done professional event. And it's really interesting for me as from a personal journey. I think I've experienced a lot of shame for my identity, and I think we can all relate to that.
I'm a Welsh girl from the middle of nowhere. I had sheep to speak to when I was younger,
What better company?
Yeah. So, and I mean, it's the kind of place where when I came out to my family, they were just like, well, you're the only person, which is quite funny because, of course,
you weren't.
No, I definitely wasn't. I was like, but what about her up the road? And what about him? So, I've experienced a lot of shame for my identity. And it was really interesting because actually this work has really given me so much personally in terms of connecting with my community, which I didn't think, I just didn't envisage that would happen. And the event felt like a big hug from the community to me and from me to my community. So it was very self-affirming for me, extremely. And it was very moving. I found it, really fantastic. So, and that's how Stewart and I met. And then, so Stewart also works with Alison Berner, who is an incredible clinician and researcher. Watch this space for further research looking at alternative methods of cervical sampling within the LGBTQIA plus community.
Interesting. Alison Berner. Bloody wonderful, isn't she?
Fantastic.
Yeah, she
and,
is.
and there's another point about this innovation in screening as well that I think is really good. So when we do work for our community, there's also the benefits that it helps others as well. So it's just extra weight that moves forwards the idea that this is acceptable, it does work, and it can work for people then, for example, who may be trans or maybe have vaginal atrophy after taking testosterone, so that makes speculum insertion more uncomfortable.
Yep.
It might be people who are survivors of sexual assault and have vaginismus. There's like all these different things that actually just add further weight to the fact that self-sampling is great. You can do it at home. And not every person will want to do it. Some people won't feel confident and they'll want to go to their clinician, and that's absolutely fine. I don't think it will completely take over the market, but it's just another option to empower people to access life-saving screening.
Yeah. Well, that was going to be my next question. Like, what other communities could this potentially benefit? And like you say, sexual assault survivors, the idea of having an intimate examination must be really, really triggering. So, I mean, I know your research is very much founded in this one community, but the breadth of it and the ability of it to kind of encompass people that have been through trauma is just unbelievable. And applause to you all.
Another one is modesty. For some people, it may be a case of modesty, so therefore they want to be able to do it at home, And also the other one that Jen touched on right at the beginning is if you have time. Jen obviously is talking about that in relation to getting time off work and also fitting it around your menstrual cycle and all these things. But also Joe's Trust just did the whole campaign of trying to get employers to let you take time off to go get screened. The more we can give it to people so they can do it on their own time and send it back, which we've done in other spaces, like sexual health have this, where you can order a kit. So we should absolutely be moving forwards for it for screening.
And also caregivers as well, people who don't have time because they have children or they have people who they have to look after. And it's just so difficult to find time to go and have that screen. And then if it's a little bit delayed, which unfortunately, we have pressed services, then that takes even longer. And we talked about the practical things like not being able to have it at that certain time of month, etc. So there's a lot of barriers there. And also, of course, we've just gone through a pandemic times, I don't know how many waves did we have. And of course, that we know that the evidence shows that, there's going to be an increase in the number of those with cervical cancer. Yeah. Because we had a 6-month hiatus in screening for some parts of the country. So, this is an ample, perfect opportunity to be able to screen, but with no face-to-face contact. And just be able to send that out and send it back to the lab and that's it, and get a result. And then we know who's at risk and who isn't, and who needs further investigation rather than, having to go and have that face-to-face contact, that appointment. And, who knows in the future, hopefully not, but we may get further pandemics. I mean, that's what's predicted. And so therefore this would be a really good backup to ensuring that we don't get that increase in cervical cancer cases. Yeah.
And like you've said, Stewart, it's not here to replace, it's here to include. So those people that feel really comfortable about going to their GP, speaking to them, having that face-to-face contact, that option will always be available for them. But it's that, that additive that's really, really important for people. And it's great. And I mean, I know I might be speaking with an echo chamber effect, but a lot of people that I speak to that are my age, which is like 24, 25.
She's so young.
I'm so young. I'm a little baby. But yeah, speaking to them just about this, it's like, the question is, Jen, when is it available? Because, you know, I don't think it's positive that there's this kind of prevalence and dissemination that cervical screening is a horror, because a lot of people don't find it a horror.
True.
But then for some people, it really, really is that thing that there's just major barriers, and the thought of going for a cervical screen is just beyond them because it's so traumatic. So you're really helping people here, you guys.
Thanks. Yeah.
Like
we'll give credit to Professor Crosby, shall we?
The gynae goddess.
Yes.
Let's give her some applause. And I mean, just back to the question that I kind of flagged earlier. So rebuilding systems for inclusion of minorities, and it's often seen as an option. What would both of your responses be to that? Because it comes up quite a bit. I've witnessed it coming up, and I kind of, in my opinion, I'm like, well, what is a minority to you? But I mean, what is your guys' take on that?
It's an option or an afterthought, right? Those are the two things.
Yeah.
Yeah. And obviously, any time that you don't provide equitable healthcare, you're creating poorer outcomes for that community. And I think we've moved past the stage of that being almost ignorance and accident. And now it's got to the point where we have the data, we have community voice, we have these things, we have PPO, we have co-production, we have these tools. So any further exclusion feels more active and therefore needs to be addressed. And there is amazing work that's always going on in these areas too. So obviously the data was never going to stack up against the huge national registries we have and things like that. So that sometimes can be one of the things that's used, especially against the LGBT community when it comes to research. You know, you don't have the numbers, we can't make these suggestions, that kind of thing. But when NHS fails to record sexual orientation or trans status in its clinical record, we'll never have those numbers. But that doesn't mean we shouldn't be making progress.
Yeah.
So it's thinking again on that bigger picture. And I think for too long, cancer care has seen equality in silos. It's seen it in ethnicity and race, and it's seen it in disability, and it's seen it in other aspects. And actually, when you bring all these voices together, we tend to converge on common themes and common recommendations. And I think there is something to be said about Jen's work and people like Jen, because it's also building community understanding and trust in screening, what it is, how it works. People even currently don't understand what the existing format of cervical screening really does. But we need people to understand what these innovations are when they come in, so they're more likely to take them up. And we saw this from Wales, when Wales increased that window between appointments, and there was a lot of confusion and fear about it. So I think when we think about this stuff, it's thinking about how do we make the research inclusive? So do we have representative samples? How do we make its administration inclusive? Are we relying on existing systems, or do we need to build a new one? And also, how do we make the messaging inclusive? Are we speaking to people in a way that they understand? Are we using language that they recognize? And that's also when we think about people who have English as a second language, or people with learning disabilities, aspects like that, so they can still access these innovations and they're not almost ring fenced for people who are the sort of majority patient.
Yeah.
You know, one of the things that I guess I'm quite proud of is that in my general work within the colposcopy clinic, our initial survey of acceptability of urine sampling didn't have anything on it related to gender identity and sexual identity. So we added that. And I just think it's really powerful watching people fill that out. I mean, obviously, you know, you're not meant to look, but it's just me and that person in the room. But it's really interesting because it stimulates discussion, even amongst people who don't identify in that way. And some people like giggle a bit, you know, it makes them feel a bit uncomfortable, you know, and maybe go, oh, why is this here? Yeah. But I mean, even if that is the reaction may be a negative one. Is your gender the same gender as you were assigned at birth, for example, is a question. But it is stimulating discussion and making people think and go, oh, actually, yeah, okay. So there are there are people who may take part in this research, i.e. have a cervix, and actually, not identify as a woman.
Yeah.
So that's been really powerful. So from a research perspective, I always tell people, include these things. Don't be scared of people being offended. My research also has about 20% of individuals who identify as in an ethnic minority group. And the research also is about 10% that identify as LGBTQIA+, which is great because that's how many, that's the percentage within the general population. Yeah. So, and people are often worried that we're going to offend different people from different cultures, et cetera. But I just think we just have to normalize it in some way, but make it visible. We can't just ignore it and go, well, this isn't an issue anymore. We need it to be there and obvious. And by doing that, we're normalizing the conversation and saying, we exist. We're always going to exist. We always have existed. And, we deserve a voice just like anybody else, any other human being. Yeah.
Could you tell me about your work on inclusive pregnancy status, IPS?
Oh, yeah, of course. Yeah. I wonder where that was going to go. So the IPS is the inclusive pregnancy status, and it's something that I co-wrote with the Society of Radiographers. And basically, Lizzie gets the credit, actually. Lizzie started this off, Lizzie Scott, and she's an advanced therapeutic radiographer, if I'm remembering this correctly, and in Leeds, and was looking at, well, why don't we have a way to really support this questioning of who's coming in when they're having their diagnostic or therapeutic radiography? How do we check that they're not pregnant? And a lot of it got inspired by the fact that there was actually a CQC report, I think it was, of a trans guy who was irradiated whilst pregnant because no one had asked the question. And that's kind of where it comes down to IRMA law. So that's your radiation law. And on IRMA, it basically says it's quite gender neutral in its language, that we should be making inquiries of people with the potential for pregnancy within certain age limits. And it however, doesn't really give you any guidance on how to do that. And then the RCR kind of did a document afterwards that gave suggestions, but again, wasn't very specific, but it basically said it's up to local people to figure out how they're going to do that. So what the IPS does is it gives people a tool to do that safely and effectively. So what we have forms that allow people to, as Jen was touching on, give questions about sex registered at birth and things like that. So they might be able to share that information. There's a very long document of guidance that talks through why this exists in the first place and talks through the clinical examples. It goes over things like not only the issue of making sure we check someone's potential for pregnancy, but also some myths that exist in the community that testosterone is a contraceptive when it's not. And also making sure as well that patients feel safe to disclose and that the clinicians understand why they're asking it too. Yeah. Because when you give a tool to people in practice, they're not going to use it unless they understand the benefit, because it's just going to feel like one more thing to do in a busy clinic. So we did like little test runs, as it were, in different clinics, and it went down really well. I think there's a lot of fear about, will people understand the form? Will people get offended? And actually, it went down super well. And then once we'd done that and we got some data, we finished writing it up and sent it out. And it again is just this aspect of the little extra tick box is going to potentially improve people's lives. That's the outcome.
You've discussed about how you're informing people to ask that right question and ask the question that's potentially going to save lives or save a life. How have you been working with healthcare practitioners on kind of inclusion of studies such as Jen into adoption into general healthcare?
Yeah, so if we take the IPS example, we understood that you can't just release this quite heavy document and send it out and expect people to just, lap it up and put it straight to practice. And ultimately, because it's an SOR piece of guidance, it's, from them, it means it's, it's somewhat optional. It's if people want to take it up. So the way that works is then you have to educate people. Why does it exist? How do you implement it? And we did a webinar, and it was super well attended, and it was hosted by the SOR. And it just shows that you have to take a multi-level approach. You have to engage people. You have to check what they want. You have to check their existing practice. You have to see how you can shift it ever so slightly so you get the change you want without completely rewriting the whole process. And then you have to educate them on why you've done it. You have to almost cover all your angles and make sure they understand why it exists and that it's been well researched. And then, also have your back channels for evaluation and all these kind of things. So we did that with SOR. As a charity, we also provide webinars to healthcare providers so that they understand where LGBT identity intersects with cancer experience. We do that from a cancer patient experience point of view. We also do it from the clinical incidence point of view. So when we talk about cancer risk modulation as a result of exogenous hormone use, those kind of things, or vaginal atrophy from long-term testosterone therapy and how that might change your sample taking. So it's those things that I think sometimes really excite clinicians, because they understand that actually there's something clinical going on here. It's not just the zeitgeist of wear a rainbow badge pin, which is part of the puzzle.
Yeah.
But there's actually something here that's about patient outcomes.
Yeah.
And we touched on it earlier as well about sexual wellness, checking in with the patient about their sexual plan. And if we think about the attention given to queer women in regards to sexual wellness, going through treatment and coming out, whether that's radiotherapy or surgery, the lack of attention and support they have and the lack of research to support them is shocking. There is a fantastic PhD out there by someone called Joy Hall, who I've spoken to recently, and it's something that Lizzie, again from the IPS, is exploring. But it's this idea of, why do we have these gaps? Why isn't it a priority? These people are out there. They absolutely deserve answers like everybody else does. So as a long rambling answer, it's about connecting the whole picture. Clinicians in the field who are really trying new things and doing best practice. Third sector, patient voice, people like Jen doing research that's at the cutting edge of innovation, evaluating the existing pitfalls, all of that stuff. And the more that the cancer sector speaks to each other in this way, the more that we can create a solution that works for everybody, rather than it feeling like one person's gone rogue.
Yeah. Exactly. And there's not just that path of research to patient. There's a hell of a lot of involvement behind the scenes.
And that path is so long.
Yeah.
So I used to do research a long time ago before the charity thing. And the thing that frustrated me most was you come up with a fantastic theory, but it's never going to reach people for another 5-10 years.
Yeah.
So that's why sometimes it's useful to bring in these ideas of co-production and community involvement and this kind of stuff, because not only does it help them feel like it's a tangible thing on the horizon, but it also creates that momentum and drive for clinical services to adopt the change, because they have a subset of general population who are willing to take up this new direction.
Exactly.
Yeah.
How do you envisage your research kind of getting into that healthcare continuum? Do you think you'll work with Stewart?
Yes, for sure. I think for me, I'm really... I've still got some research to do, so I'm about to start some interviews. So delving deeper into the acceptability of self-sampling, urine sampling for cervical screening in this community. So really excited about starting that work because it's also part of my learning process. And I think it's going to be really interesting to be able to have these conversations that are more personal than just a survey. So we'll be able to put those two things together and get a real sense of what our community want from screening, which is going to be so powerful and be able to shape the future of cervical screening in this country. I mean, that's what's incredible about it. A community where we've not had a voice in so many things because we're always an afterthought or just not thought about. So it's really exciting to be doing that. And obviously, I'm sure there will be more work being done in this space with our communities. So.
Wow. And Stewart, coming to you as kind of hopes for the future, what are the hopes for the future of Live Through This?
For me, it's making sure we reach more patients so they don't feel so alone like I did for so many years. And, we're reaching new people every month. People get signed up to our peer services. But, if ever there's a patient out there, absolutely get in touch. We continue to educate healthcare providers, making sure that they feel confident to provide good care so that it reduces the negative experiences people have when they find us, obviously. And we continue to put out new information so that people have campaigns that speak to them. They're likely to access things. And then watching people like Jen with great interest about where the research is going and making sure that we can then, as a charity, help amplify the message when this urine self-screening or self-sampling finally comes to market, and we can get people doing things maybe in the comfort of their own homes if they want.
Viva the urine test.
Indeed. Amongst other things, of course,
yes, obviously.
So we can do sexual sexually transmitted infection, other ones. We could add it to, other potential cancers. ... Wow,
you guys, honestly, thank you so much for talking with me today. And I think also thank you for sharing personal experiences. It's a lot to do. It really is. And it can bring up previous trauma. And yeah, I really appreciate it. But I think as well, just like the work that you do is incredible. And I not that I'm going to affirm that in any way, but I'd love to tell you what, great stuff that I think you do, because it is just incredible. Because it's saving lives at the end of the day. And yeah, if there's anything that is more powerful than inclusion, there isn't. So yeah, thank you.
Thank you.
It's the nicest outro I've ever had. Thank you.
I'm not quite sure how to respond.
Yeah.
Just say thank you and keep
Thank you so
quiet.
much. And also thank you for your incredible podcast series. You do an amazing job as well.
Listen to season 1, guys. But yeah, thank you, guys.
Thank you so much.
Bye. Bye.
If you have been affected by anything you've heard in this episode, please see the show notes for a list of charities and organisations that can help.
1 in 2 was brought to you by the University of Manchester and the Manchester Cancer Research Centre. Listen to our next episode to hear from more of our researchers as they share the innovations, discoveries and projects that are changing the landscape of cancer prevention, early detection and treatment. To find out more about what you've heard today, please see the show notes for this episode, where you'll find a transcript and links to further information and research. Cancer is one of the university's 5 research beacons, showcasing the interdisciplinary collaborations and cross-sector partnerships that are tackling some of the biggest questions facing the planet. To hear more about Manchester's research in advanced materials, biotechnology, cancer, energy and global inequalities, go to manchester.ac.uk/beacons.